Yeah, Lawrence Garcia. I'm an interventional cardiologist out of, just changed my practice. I'm going to be at St. Francis Hospital in Roslyn, in New York. I get the honor of trying to describe what we don't know about these trials that have failed for the below knee space. You know, the below knee space has been really a fairly aggressive area that has been worked on by many of the strategics, and without a doubt, all the trials that have come before it have really been negative. And the reason for those negative outcomes, up until just this past week, where we had this very, the first positive trial, which we'll get into, the problem with the preceding trials has always been that they have really focused on a heterogeneous group and have never been able to focus the trial group to one or a series of very specific patients. And when they bite too much off of that apple, the challenge is you don't get a signal of positivity. And so one of the challenges has been, you have some folks that have looked at Rutherford's 4, 5, and 6. Some people have looked at Rutherford's 3 and 4 and 5. Others have looked only at 4 and 5. And the challenge is that you can't get a specific question answered when you have that kind of morass of patients. The other thing that's been very challenging is that whether it's device or balloon, every trial has had this really difficult time of defining what is successful. So the endpoints, not only the patient population being so diverse, but then the endpoints are never very specific. And when you pick and choose that target, wherever you're shooting your arrow, it has to really hit the mark. And with all of these trials, because they have so many diverse outcomes, I think, again, they've taken too much, too big a bite, rather than focusing in on one answer. And, God love them if it had turned out positive, but every one of these trials just turned out negative because, again, they just didn't have the right signal. Now, this past week, we had one trial that was positive, which, to Abbott's credit, they really stuck with what they wanted to know, and they very, very specifically focused on only 2 patients, right? The Rutherford's 4 and 5. They focused on their outcomes to be in the upper 2/3 of the tibials. And then the outcomes, which were powered not only to a primary outcome, which was a primary patency, but then they had the secondary primary effect as a secondary outcome, still powered. And so for all the trials that went before it, that secondary outcome was still very well powered to the outcome of their trial, which showed the benefit, but their primary benefit not only separated early, about 4 to 6 months, but then it actually persisted out to the 1 year, which was our first real positive trial. And I think all the trials that have come before it, now very specifically, all trials coming after it, will have to probably follow that MO, or that modus operandi of the patients enrolled to the outcomes that they're going to focus on. Technologies have been progressive, and one of the beauties of what we've done in the periphery has been that the simplest of simple, which has been simple balloon angioplasty, or what we call POBA, has been around for eons. In all the major vascular beds, coronary, as you asked, the periphery, in the above knee, iliac, renal, subclavian, all of those other territories have shown benefit of not just balloon angioplasty, but rather some other surrogate, whether it be stenting, drug-eluting stents in the coronaries, standard bare metal stents in like the iliacs and so forth, and the SFA having not just a balloon, but a medicated balloon. The problem has been when you translate or transfer down to the below knee space, the challenge there has been that although we have a myriad of devices and they all look great, none have been proven effective. And so you fall back to the simplest, which is balloon angioplasty. And so it's really challenging when you go back to before LIFE-BTK. Every predicate device is tested against what's the standard of care today below the knee, which has been angioplasty. So what's old again is new again when it comes to the below knee space. And the challenge there is that POBA gets you so much. It can open up the artery, and from a very poor man's perspective, amputation-free survival is useful, but the outcomes against that metric is very, very challenged for any other device to then test against. And that's where, again, if you look at LIFE-BTK's success, they looked at primary patency to the scaffold, spiroresorbable scaffold. And so that's the one technology which has shown benefit, again, against the outcomes, which are primary patency in the first and second powered endpoints for their study. Critically, from just a pragmatic standpoint, as a scientist and a physician who takes care of patients with a lot of vascular disease and below knee work is part and parcel of what we deal with. the benefits of LIFE-BTK are fantastic. We have a first victory, so that may lead the way for other trials. The challenge is that what LIFE-BTK answers is a very specific cohort of patients. So relatively short, although it's a modest lesion length, not terribly calcified, only Rutherford's 4 and 5, working in the upper 2/3 of the tibials. So when it comes to real-world patients, whether or not it goes through a PMA or some form of registry, those are the major unanswered question, which is the real-world patient. Longer calcified arteries at the ankle or inframalleolar disease. These are the bigger questions that, whether or not it becomes a single therapy, i.e. a bioresorbable stent or, drug-coated sirolimus-based balloons, whatever your device will be, it has to then be involved with those patients that have not only upper 2/3, but malleolar, inframalleolar, and even pedal disease. And ultimately, that's going to be the holy grail when it comes to CLTI, just not a very specific patient, but what we see in general.